I see you and Kay and Carmelita.
Yeah, I think Carmelita and Kay will be presenting.
Okay, well, welcome so much, both of you, for coming. I don't think you guys, Carmelita and Kay, always have time to join, but you're always welcome. So please come whenever you can. Usually most people join between 12:01 and 12:04. So we'll give it another minute, and then I'll just do like a couple of quick announcements at the beginning. Do you guys have slides that you want to share?
Yep, we do.
Okay, do you want to try sharing it, or you feel just to make sure?
I can go ahead and share it. I'll be right, just pull it up. Sorry, I'm so much used to, I'm much more used to Teams, so the Zoom is throwing me off a little bit. There we go.
Oh, that looks perfect, Kay.
Thank you. Whew.
All right, well, just as people are joining, I don't need to show any slides for this actually. So welcome everybody to our Friday conference. Today we're going to have start off with a talk from a couple of the members of our Bartlett team on our early intervention services. I'll turn it over to them in just a minute, and then we'll have a case at the end if there's time, but we can also, it's not an urgent case, so we can defer if there's good discussion happening. And then the next 2 weeks are also open for cases. So this is also your cue to email me or text me or somehow or other tell me if you have a patient you'd like to discuss. We have a couple of cases we can revisit for follow-up, but like also would love anybody with new things to discuss. And then some upcoming things that I'm working on, a motivational interviewing session with Dr. Heidi Hutton, some updates in primary care that Gail Birkenblit has agreed to do. And then Dr. Anna Durbin is going to come with an update on vaccination recommendations for people living with HIV. And just wanted to also use this just a minute or so to anybody who has suggestions. One other one I'm working on, prior request from Julie MacArthur, is on like multiple myeloma and hematologic abnormalities in our patients, especially since our consultation is pretty limited. And then any other suggestions, please send them along, because we want to make this useful. So everybody tell us how to be most useful. Okay. Well, and again, the ways to do that, you can chat me or email me. If you're emailing about a patient request, just write secure in the subject line in the brackets. And then everything is all kosher. So at this point, I will turn it over to Kay Park, Carmelita Abel, and Joyce Jones, who are going to talk to us about early intervention services and how we're going to end the HIV epidemic.
Hi, everyone. I just want to say thanks for having us. We wanted to take the time to reintroduce early intervention services, as well as ending the HIV epidemic telehealth program services within the Bartlett Clinic. Again, my name is Carmelita Abel. I am the new HIV and AIDS program manager within the Bartlett Clinic.
And hi, my name is Kay. I'm the clinical nurse at the Bartlett Specialty Practice, working with the EIS and EHE program. Thank you for having us.
So here we just wanted to share a picture of our team. This picture is a picture of the EIS and EHE team, as well as the ED team. Next slide, please. So now we're going to go and Kay is going to do the program overview.
Yeah. So we'll start with the EIS service. The purpose of this program is to provide in-person HIV testing, PrEP, HIV treatment initiation and reinitiation, but we really focus on just status neutral linkage to care, making sure that all patients, no matter their HIV status, get linked to education, to HIV prevention, and to HIV and treatment and care if they are living with HIV. So part of this program is our testing and counseling program. We do provide testing and counseling at the clinic. It's offered Monday through Friday from 10 a.m. to 2 p.m. on a walk-in basis. And it is point of care rapid HIV and hepatitis C testing. The emergency room also provides testing on an opt-out basis, which they can do 24 hours. For our PrEP services, our PrEP team includes a program manager, a navigator, and a nurse to assist with linkage and referrals. And then we have the HIV Rapid Start and Rapid Restart program, where newly diagnosed patients are offered a Rapid Start evaluation and linkage to care. Often we try to do that within the same day, or at least by 48 hours. And then previously diagnosed patients are offered rapid restart evaluations and linkage care. And we offer all clients navigation services. So our EHE program, also known as the Ending the HIV Epidemic telehealth program. So we are using telemedicine to provide HIV testing, PrEP, HIV treatment initiation, and reinitiation. And again, we're focusing on status neutral linkage care. So we are working with I Want the Kit. So that is STI home testing. So we actually get a list of clients who opt into navigation services, and we respond to those navigation requests, and we offer assistance with the testing process. We also offer HIV and STI education. If patients want to get engaged with primary care, we can assist with that. We can also help link them to mental health and substance use treatment, housing, and insurance. And then some of the new novel ways that arose during the COVID pandemic, we wanted to offer more telemedicine services. So we have initiated PrEP Start and rapid HIV treatment initiation via telemedicine. So patients who are looking for PrEP can actually meet with a provider or a PharmD to get an evaluation, and we can help them get started on PrEP. To start PrEP, we can order lab work to a freestanding lab or to the Johns Hopkins lab, but we also can order in-home lab testing through molecular testing labs, and they use dry blood spots to collect creatinine, Hep B, Hep C, fourth generation HIV test, syphilis, and then patients can self-swab to collect gonorrhea and chlamydia. And then also they can collect urine. And then they get a telemedicine follow-up or an in-person follow-up with the Bartlett provider, depending on what their preferences are. For the rapid, yes.
Just a super quick question. So what's the insurance requirements for accessing these services?
So they do have to have participating insurance. So Bartlett does need to accept their insurance to participate. But if we don't accept their insurance, then we are going to be doing a warm handoff to another, clinic or an organization that can help. And then that's the same with the rapid HIV treatment initiation. If we don't accept their insurance, we're always going to make sure that they get into care somewhere else. So the rapid HIV treatment initiation, that was really helpful during COVID because a lot of patients were getting telemedicine appointment intakes, and instead of having to come in, they were actually meeting with a provider or our PharmD to get evaluated for Rapid Start. And then we would ask them to follow in person, but at least the initial process, we were able to meet them on the telemedicine platform, which for a lot of patients made things a lot more easier. And then again, all of these clients get navigation services. All right, so talking a little bit more about our testing and counseling program. So testing at the clinic is confidential, voluntary, and free of charge. And again, our testing hours are Monday through Friday between 10 and 2. I don't know if everyone, gets the e-huddle, and but our tester of the day is always listed on the e-huddle. And then individuals who test negative will be given post-test counseling and referred to PrEP if they are indicated. And then individuals who test positive will be given same-day scheduled appointments with the EIS EHERN, which is me, or they will meet with the hepatitis C case manager if they test positive for hep C, and we can arrange for confirmatory testing and then linkage to care. All right, so we're just going to go through the workflow for the HIV and PrEP linkage. So for linkage to HIV care, we get referrals from a lot of different places. So we get external referrals. Usually it's, primary care clinics. We get some referrals from Patient First, EBMC. We also have a really close partnership with the Hopkins Emergency Room and the inpatient teams. And then a lot of patients actually find the clinic by themselves, either online or someone has told them, so they can actually self-schedule. So the first step is getting intakes. We do ask that all patients go through a nurse intake and a case management intake just to make sure that there aren't any barriers to care that we could mitigate before they see the doctor. And then we also want to collect some baseline information. So the nurse intake, so we're assessing their status. Are they newly diagnosed? Are they previously diagnosed and out of care? Or are they just moving to the state, wanting to transfer providers, etc. Then we're going to get some medical history on them, and then we're going to be doing the mental health, substance use, and sexual history assessments, going through any current symptoms they have. And then if they are newly diagnosed, we also want to see if they are eligible for virtual rapid start. We basically want to ensure that they don't have any acute symptoms that need to be evaluated, and that they are comfortable with the telemedicine platform. And then we're going to refer them, depending on their status. If they are a possible rapid start or rapid restart patient, then we want to get them in as soon as possible for that evaluation. If they are just transferring care, already on meds, stable, then we would refer them to a continuity provider, ideally within 1 month. But some patients haven't moved here yet, or they had just recently seen the doctor. So we work with the patients to, figure out when they can come in. And we also try to refer to mental health and substance use treatment. And then, of course, we offer navigation if we think that they would benefit, or, or even if they don't, we offer navigation. Patients also work with a case manager, which is incredibly important for our clinic because they can get Ryan White services, which can help them not only with getting financial assistance with their care and treatment, but also other resources. So case management can help with same-day medication coverage. So if they're uninsured or if they're undocumented and uninsured, then they can help figure out a way to get medication same day. They can also do insurance verification and then help with getting insurance if patients are uninsured. And then again, Ryan White eligibility, and then the Maryland ADAP eligibility, and then they'll do transportation, housing assessments. They'll refer to dental, legal, and they'll also do a psychosocial assessment to see if there's any areas where we might be able to assist. And then finally, patient will meet with their medical provider. So again, if the patient is eligible for rapid cert or rapid restart, they can discuss their situation with the provider. And then, of course, they'll be linked to HIV primary care. All right, I'm going to let Carmelita take over now.
Okay, so now we're going to go over the linkage process for patients who are interested in PrEP services. So we do receive referrals externally, internally, or the patient has the option of walking in to receive services or contacting central scheduling. After the patient expressed interest in PrEP, we do what is called a PrEP intake. So we assess them by obtaining demographics, kind of see like what their needs are, if they need substance use services, mental health services. We do a social determinants of health. We confirm if they currently have a PCP. If they don't, we do assist them with obtaining one. If their insurance is not accepted at Bartlett, then they will go external. But ideally, if their insurance is accepted at Bartlett, then the provider that is providing them PrEP services can also provide them with any primary care services that they need. Any insurance barriers we can any insurance barriers that they may
Someone
have.
wants to multitask.
I know. Epic always needs to interrupt at the most inconvenient times.
Any insurance barriers that the patient may have, we do assist them with obtaining insurances, of course, based upon their income. We assist them with food. We do have food gift cards that we provide them with resources to mental health, substance use, and we also provide navigation services. The navigators pretty much kind of provide wraparound services to be there to support them with anything that they may be facing that could be a barrier with them accessing their care. After the PrEP intake is complete, we then schedule the patient to come in either for labs at the Bartlett. They also have an option to go through LabCorp or Quest, as well as molecular testing labs, which is the STI testing that could be done at home. We do encourage the patients to have that the labs has to be done within 7 days of their scheduled visit. And during their first visit, they are prescribed PrEP. Now, currently we are in the works of adding Apretude injectable PrEP as an option for patients. So just be on the lookout, that should be coming soon. Next slide, please. So now we're going to kind of talk about navigation services for both HIV and PrEP patients. So just to kind of highlight some things that the navigators do, they provide appointment reminders, assist with connecting patients to providers in social work for services, assist them with scheduling and rescheduling their appointments, any medication refills that they may need, labs. They do wellness check-ins. They also provide patient escorts for medical procedures such as colonoscopies. We also provide assistance with obtaining food gift cards, phones so that they're able to connect with their provider and their medical team. We also provide transportation to and from their appointments. We educate patients on the importance of self-advocacy, and we also offer some groups for patients: Link, Poetry Slam, the ACE group, and Latino X. Next slide, please. And we wanted to share some information on how to refer patients for services. So for rapid restart transfer of HIV care, referrals usually go to Kay, and you can reach her through Epic, Secure Check, Secure Email, or by phone. For PrEP linkage, you can give me a call, or you can send me an Epic check or send me an email. The backup, I meant to mention, the backup for Kay is Leon James. And the backup for me for PrEP referrals is either Ayana Copeland, who is our EHE navigator, and Wendell Saunders, who is our EIS navigator, and they can be found in the navigator room. And we also do have a navigation hotline. So if you just want to provide your a patient that might be interested in PrEP with a navigation hotline, that is a number that is available for patients to use to be connected to PrEP. For Link and ACE navigation services, you would send an email to the navigation services email, and you include the patient name, the date of birth, their Jet ID, and a detailed explanation of services that's being requested. And for EIS and EHE navigation services, you could reach out to me via Epic or email or by phone. Next slide, please. And does anyone have any questions for us?
I don't have any question. Well, I have one question, but I just want to tell you all how wonderful you are. So a couple of things. So first of all, you've been absolutely instrumental in helping women postpartum get into care. That linkage has always been very difficult, and I don't think we could do it without you guys. That's one thing. Secondly, I'm going to be bragging on you at our site visit for Ryan White Part C, because this is just what they're looking for. So I may come and pick your brains a little bit before then. And then just one question. I'm just curious, you may not know this. What is the percentage of our clients who test negative who actually accept PrEP?
That's a good question.
Joyce, you might know this. I say personally, PrEP is always, we're always trying to get people on PrEP.
Yeah.
It's for a lot of healthy young people, they, it's difficult to
Yeah.
get them to get on any treatment. But I think we've had a couple of successes. A lot of people who never knew about PrEP were able to introduce to them just because they come in for testing. So we've actually gotten a couple of people who came in for testing to start on PrEP.
Yeah, that's great. That's why I know how difficult it is. So thank you. Because I'll probably be bragging on that too when the Part C people come. Okay, thank you all so much.
And just to get on the thank you train, Mrs. Yuka, there was a couple of patients that I saw on Polk that got directly sent upstairs by Kay, and they really needed help, and they were at the intake. They weren't even like in our clinic yet. So I think it's really critical that we see them right away. And I think there should be some way to get credit for that, Joyce, on Ryan White funds, because I think it's like super important. One of them did really poorly, and if he hadn't come upstairs, I think he would have died.
Sorry, just to say we get credit, don't worry.
Good.
That's the thing. Just to also say, these terms, early intervention services, that is a grant line in Ryan White. And that is what is funding these activities. The goal of that grant is to identify people living with HIV who are not in care. So it's one of the few Ryan White funded grants that pays for HIV testing. Because Ryan White is congressionally approved only for people living with HIV. With the advent of PrEP, we have been able to use that money for the linkage to PrEP. But just to say, that's where the funding comes for EIS. That's what pays for Kay and Carmeletta. And then we have this additional EHE funding that's from the CDC. So sorry to interrupt you, Yuka. But
Yeah, the last thing I was going to say is one of the fellows should definitely do an evaluation of the warm handoff to the clinic, because I think there are people who get diagnosed with HIV and they don't call UK, and I think that they get lost. So the residents really struggle sometimes with getting an appointment. And whenever we use you guys, they get an appointment date and time that's in the next week, which really changes whether they follow up or not. So I feel like that should be, there'd be a really easy thing to do through PMAP to see which ones didn't get called and therefore didn't manage to follow up and were given like an after hours appointment. After
Sure,
clinic.
yeah.
we
Absolutely.
try
I
to
think
have everybody, right, contact Kay. That's like the goal. So if people aren't, if people are needing connection to care, we should know about them.
I think it varies like on the hospitalist service and on some of the firms,
Right.
they don't necessarily call.
Well,
On
and
Polk, I would say we 100% call.
And I think that this is one thing, though, that we could channel better through the residency program, because they have those schedulers that they email, right? So a lot of times the residents are actually not calling for these appointments. They're sending a note or an Epic chat or some other communication to a person whose job it is to coordinate follow-up appointments. And so making sure that that's centralized to for all the services would be super useful.
I want to echo about getting this connection with, with the hospital. And wouldn't it be wonderful, because we'll have a new group of interns starting in July. And this I thought was a wonderful presentation. And I think it would be great to somehow get on the schedule to do a brief presentation about what this program is all about, so that the incoming interns and maybe even the residents know more about it, because they may not.
And I mean, they routinely send people to like the Bridge Heart Failure Clinic, you know, like there are models where like there's a known pathway of like putting patients into care. And I have to say, I'm always surprised at how many people are unaware of this. Sarah Caraba is so politely raising her hand.
Hello, thank you. I was just gonna put a plug of, I think it would also be really helpful if it's not already included in ID fellow orientation to include that, because a lot of times, particularly at Bayview, it's the ID consult team that is seeing patients living with HIV. Sometimes the consult question is like, hey, should we continue their ARVs when they're like intubated in the MICU? And the answer is, please do. But like, so just that it's often the ID team that sees people. And like, I know about Kay and have emailed her multiple times for patients I've seen at Bayview who are interested in reestablishing care at the Bartlett Clinic. And she's been wonderful and calls their rooms and speaks to them. So I think it would be super important and very relevant to also have an ID fellow orientation, just so that these services are on the radar of the first year fellows who don't come to Bartlett until second year.
Yeah, I am doing the orientation for Bartlett. So well, actually, I guess then Sarah, there's like a separate, I do it for when the fellows are coming to Bartlett, but I guess there's probably one
For the
fellows
inpatient.
in general.
Yeah,
Okay,
exactly. So for the incoming first year
sure.
fellows, they have orientation activities too.
Okay.
A
Great,
lot of it is, inpatient focused, but I think this information would be relevant for consults that they see that they want to link to care at discharge.
Yeah, absolutely. I think that's a great suggestion.
So, yeah, and on that note, I'm just thinking about our OBGYN staff and residents, and I'm going to talk to Janelle about making sure, because they do a lot of testing too, as well, HIV testing. So make sure that they know what the sort of pathway is to get help. This again, I think this is a great program, and you guys deserve a lot of credit for it.
And one other thing to mention there is that when you're the man service attending, so the general consult service attending, you field calls. So for example, I got a call from a reproductive endocrinologist who had just done routine HIV testing, new diagnosis, very unexpected. And so I linked to Kay because I know about Kay, but for some of the man service attendings who don't do a lot of HIV care, that's another source where there's like a focal point where it's easier to manage if you know the workflow.
I mean, do you think this is something like, what would be the best way? Do you think like a faculty meeting or something like that?
So there's a man service document that has like all sorts
Okay.
of things. And so anybody who's carrying one of the general ID pagers should
Okay.
have should refer to that. I mean, it also tells you how many consults you have to do, so people generally know where it is. But just in terms of like, so that there's a clear workflow and we could look and see how they've done this for OPAT. The other thing they have for OPAT is there's an actual list. And so when a patient is going to OPAT, which is outpatient antibiotic therapy, you drag and drop that patient onto that list. And so it would be a list that Kay would be managing, and people who were like being linked to care would be dragged and dropped onto that list. And that would show up as a way to track active patients and also to identify who is in charge of that patient. And an easy way to sort of communicate, oh, this person, like it doesn't require a direct chat that's responded to or an email. It's just they appear on the list, and then that communication can be done at later. I don't know if Sarah Caraba, who does more with that, if you think that would work as well.
I would actually ask Sarah Keller how compliant people are with putting people on the list, because I
Yeah.
think that's sometimes a pain point. But I mean, I think to answer the question of how to reach attendings, I think, yeah, the man document, or else even just like a quick announcement or a reminder, you know, at faculty meeting would not be bad either, because you're right, you do get a lot of curbsides, and you know, sometimes the curbsides, even from an outpatient provider, are, what do I do with this person who, you know, I just diagnosed with HIV? So
For Polk, I think that Joel passes out the document, Kay, that you made a long time ago, comes every
Oh,
time
great.
you're gonna have 2 weeks. Like, it's kind of like the idiot proof email where he puts everything in there for the people who forget. But sorry, I interrupt. Sheila has her hand up, sorry.
And now I'm on mute. I appreciate it. So I know something that was helpful when we were doing the MPOX, and it's still in existence. And I don't know if this would be helpful or not, but we created a mailbox for MPOX evaluations. So, you know, we didn't like make it public, but it's still in existence. And if people outside of Bartlett wanted to refer someone for an MPOX evaluation, they filled out a little simple form and they sent an email to this MPOX email. So I don't know if that would help on the inpatient units or not. If we said, hey, if somebody needs linkage to care, this is a mailbox, and that Kay and Carmeletta could be monitoring that mailbox every day. Just an idea. Don't know if it would work.
Yeah, I mean, I think, you know, it sounds like these are all important strategies to just get the word out, right? So I'll reach out to Michael about the ID fellow orientation. And then I will also, maybe should I touch base with Paul about the man, or Sarah
the-
Keller?
The man
Yeah.
document goes
Yeah.
out with the "you're coming on service" email also is attached to that. So if they just add that in to say if you're,
Okay.
that
Yeah.
it would be pretty easy, I think, to put it on there. And I should check and make sure it's not already there, but I don't think it is.
So this is an email sent to the ID attendings that are coming onto the man service.
Correct.
And who organizes that email that comes out?
Paul Allwater is like the
Okay.
overseeing person, and I
Okay.
will check the document after this conference to make sure it's not already in there.
I mean, I doubt that it is, you know, we haven't really communicated. With oh yeah, and the inpatient pharmacist on Polk. And we can just touch base with Joel again. Like
Yeah.
you know, we have worked closely with him, and you know, we're working actually on a report that would generate all of the people who living with HIV who were hospitalized, and to do chart review. That was in process, but then kind of stalled, and we have been trying to get that to happen. But that was another strategy that we had, was to actually just get data from Epic, and then we would proactively do chart reviews, you know, to see who is out of care, basically, and then reach out to the team.
Yeah, that's the way we handled it in Boston, and it was way smaller numbers, but and the person who reviewed it was the HIV fellow. But the other people to reach out to would be those scheduling coordinators that the internal medicine residents use to schedule follow-ups. I think it's just a few people, but like as part of their like intern or resident duties, they like just send them an email saying they need these follow-ups. And so if that person knows to respond back and say, is this an EIS follow-up, or like, you know, or what kind of follow-up it is, then that might facilitate, because then basically all they have to do is contact Kay. It makes their job easier. I'm sure they'd be excited about that.
And one other thing, you know, we're available not only for linkage care, but we want to know about anyone newly diagnosed, because then we can offer our assistance with getting them started on ART inpatient and then getting that paid for, because a lot of the times that's the issue that doesn't arise until discharge, and it's everyone's like scrambling. So we always you know, want to provide our assistance and get people out on medications, you know, if we can.
Kay, is that true for patients at Bayview as well, or just at JHH?
Absolutely.
Okay,
No,
great.
patients at Bayview as well. We are completely agnostic to where, you know, referrals come in for or assistance is asked for. We always want to help people, you know, stay, you know, get started on treatment and stay on treatment.
Thank you.
And then even if they
course.
cannot follow up with us, right? Again,
Mhm.
because we have this grant funding, you know, that is our role, right? Is that people who have HIV, who are not in care, that we're, you know, as fast as possible, getting them on treatment and then helping ensure that they have continuity care. So that's what,
Okay, that's good to know.
Yeah.
Thanks. I mean, like, as Bayview draws just from a different geographic catchment
Yeah.
area too.
Yeah.
So sometimes people are interested in following at Bartlett and sometimes they're not for
yeah.
reasons. So that's good to know.
Yeah, and then, you know, we have connections across the city. So, you know, we have this consortium that includes Baltimore Medical Systems, which is like right there. And, you know, the City Health Department, University of Maryland Thrive Clinic, Chase Brexton. So we're actually,
So I was saying then, Joyce, could you also add onto your list, your growing list of people to contact? Similar to like a MAN info packet, there's a Bayview like email with info packet that goes out, and that is managed by Bill Wright.
Okay.
William Wright, Bill Wright, he manages
Okay.
that for Bayview.
Okay.
And so that would be helpful for the Bayview, you know, for faculty that rotate at Bayview who may not be aware that, you know, patients we see with HIV can even if they don't follow or plan to follow at Bartlett, would still benefit from some of these resources.
You know, and Mark Sulkowski, Matthew Hamill, you know, Sherilyn Brinkley, like we have just started this recurring meeting about Bayview and standing up, you know, similar kinds of services for Bayview specifically.
Great. So. Thank you.
Yeah. And I just wanted to provide an example that Carmeletta and I experienced recently. There was a newly diagnosed patient, inpatient. She was referred to Bartlett, but she lived in Prince George's County. She did not want to come to Bartlett, so we were able to link her to Montgomery County Infectious Disease Associates. Carmeletta was able to generate a Gilead copay card. She had commercial insurance, but a deductible of it was like $3,000 or something insane that, you know, of course, is hard to pay for anyone. So we were able to do all that, and we provided her with navigation. So we're still communicating with her.
And that's what it's all about. Like, right, our healthcare system is so complex and there are just so many barriers. And so we've really tried to figure out as best as possible to overcome all of those things. So it's a great, wonderful team. I also want to, if you can go back to your navigation slide. Yeah, I guess this one. Okay, so lots of partnerships, right, in all of this. So Kristen Kilcrease is like a huge part of this. She is our pharmacist. She helps with the workflow. She's doing the she's doing the PrEP telehealth starts. And then also, you know, we've been focusing on, again, the EIS is really that linkage, re-engagement, start, and then very importantly, we have continuity. So we have wonderful continuity navigation, including the link team run by Siobhan Solano with Patrice and Moses, who after the first 6 months of, you know, sort of re-engaging in care, New Start, can transition to navigation services with Patrice and Moses. And then, as Kay mentioned, the ED team great partners. Sarah Reeves Gray gave a shout out, great BCHD partners. So, it's super helpful to have, not just the team at Bartlett, but, all of these collaborations so that we can, help people get the care that they need.
Well, awesome. Thank you so much. And Joyce, I will follow up on that MAN document as soon as we're done with this to make sure it's not already in there. But then that will be great, because I think the one reasonable predictor of success is if you've been connected, and everybody loves Kay. So
Yeah, Kay's
Thank you.
amazing. Carmeletta's amazing.
Mhm.
She's new.
and
But
Carmeletta, I
Yeah.
don't mean to exclude you. I just
No, it's okay.
I've worked with Kay now for so many years that I just know that if a patient talks to her on the phone, that there's a higher probability that they will ever be seen again. I'm sure the same is for you, and thank you for everything that you're doing.
No, Kay is
Yeah.
great. Anytime a patient is in the ED, she's like, hey, can we walk over to the ED and go see this patient for services? I'm like, yeah, sure. So yeah, no, she's great.
Yeah, just pulling Carmeletta away from her work and her desk. Sorry, Joyce, I apologize.
No, that's what it's all about. Thank you. We're so great to have both of you here. You do just a wonderful job. So thank you so much.
And
Thank
we
you.
will take these slides and post them to the Teams channel, if that's okay with you guys, so that there's a place where people can go to find them. I know we don't have always the easiest access, but these will be on Teams for anybody on this meeting who then wants to see them. Okay, and then so for the last couple of minutes, I thought we could talk quickly about a case. So I will share my screen.